Good afternoon. My name is Claudia Rose. I have my doctorate in occupational therapy, and I'm a board certified and licensed occupational therapist. Thank you so much for participating in this continuing education session on the role of occupational therapy as part of a multidisciplinary team in mental and behavioral health settings. Today, we will explore how occupational therapy uniquely contributes to psychiatric stabilization, discharge readiness, and long-term recovery. This session is designed for all disciplines working in a mental and behavioral health setting. So you know what to expect in this module. We're going to begin with a knowledge pre-check and then move into the learning objectives, background, diagnoses and statistics, the role of occupational therapy, screenings and assessments, interventions, occupational therapy as part of a multidisciplinary team, resources and advocacy, case studies, reflection, knowledge post-check, and finally, feedback. Before we start, there's a quick knowledge pre-check. I ask that everyone please complete this pre-check. Also, if you are requesting CE, know that completion of the pre-check is required. To provide a baseline for your level of understanding about the role of occupational therapy in mental and behavioral health, please complete this pre-check now by scanning the QR code or using the link. Thank you for completing the pre-check. So now we can start with the learning objectives for today. Today is designed for you to develop a basic understanding of OT practice and therapeutic interventions, to be able to describe OT's role in mental and behavioral health settings, to understand differences that are unique to occupational therapy practice, understand OT's role as part of a multidisciplinary team in mental and behavioral health. But first, I want to thank my colleagues for providing nursing and social work consultation. So thank you to Dr. Likens and Dr. Still. As a background, I would like to review a few definitions before we talk about the importance of this conversation and where gaps still remain. The goal of occupational therapy is to help individuals engage in meaningful tasks that they want or need to do in order to promote their health and well-being. These meaningful tasks, or otherwise called occupations, may include self-care, work and school, and leisure activities. We focus not just on physical recovery, but also on cognitive, emotional, and environmental hindrances. The goal is to improve independence, function, and quality of life by adapting tasks, building skills, modifying the environment, or other interventions so individuals can engage in their daily lives. Most of us are already familiar with the term mental health, but for the purposes of this presentation, I'm using it to frame how emotional, psychological, and social well-being influence daily functioning, coping, and participation in meaningful activities. So, mental health includes our emotional, psychological, and social well-being. It affects how we think, feel, and act, and helps determine how we handle stress, relate to others, and make choices. I want to highlight how behavioral health differs from mental health. Behavioral health is broader. It includes mental health, but it also includes substance use, recovery, and support for families and communities. It spans from prevention to treatment to long-term recovery. This matters because behavioral health is more system level and recovery focused, while mental health is more centered on emotional and psychological well-being. Mental illness is a mental, behavioral, or emotional disorder. A mental illness can vary in impact, ranging from no impairment to mild, moderate, and even severe impairment. The key point here is variability. Some individuals may have no impact on their daily life, while others experience severe difficulty completing meaningful activities, such as getting ready in the morning or taking their kids to school. This range is very important for us, including OTs, because it guides how we tailor evaluations, goals, and interventions to each person's level of functioning. Serious mental illness is a mental, behavioral, or emotional disorder that results in serious functional impairments which substantially interfere with or limit one's ability to engage in major life activities. Serious mental illness is really about the level of functional impact. This means the condition severely interferes with daily occupations that the client wants or needs to do. This helps us identify individuals who need more intensive and ongoing support and services. So why does this conversation matter? Healthy People 2030 highlights social determinants of health, which are key drivers of outcomes. The 5 social determinants of health are economic stability, education access and quality, healthcare access and quality, neighborhood and built environments, and social and community context. I don't have time to review each of these in this module, but here is a link and QR code to Healthy People 2030 for those who want to take a deeper dive. Readmission is often tied to social determinants of health, not just symptoms. Inpatient psychiatric services stabilize crises, but breakdowns in routine, executive function difficulties, and environmental changes can lead to return. Functional recovery is distinct from symptom remission, and with more value-based care practices, these functional drivers matter more. Barriers to recover often include serious mental illness and substance use disorder rates, rural access to services, Medicaid, and workforce shortages. Lastly, understanding roles supports earlier and appropriate OT involvement. There continues to be a strategic gap. Kentucky inpatient psychiatry excels at crisis stabilization, suicide risk mitigation, medication titration, and behavioral containment. However, symptom stabilization does not equal functional readiness for community living and reentry. Many readmissions are driven by collapse of daily routines, medication mismanagement, executive functioning deficits, sensory dysregulation, and the inability to structure time in lower support environments. OT addresses these functional drivers and challenges and helps operationalize recovery in observable and measurable ways. OT services align with Kentucky's system priorities, such as focus on documenting functional need for Medicaid. It supports the least restrictive discharge environment, helps reduce 30, 60, and 90-day readmissions, improves discharge placement success, strengthens interdisciplinary documentation, supports value-based behavioral health care, and it's important to fully leverage OT expertise to fill in these gaps. As Dr. Still and I discussed, OTs going into the community with clients prior to discharge to work on these skills has been incredibly helpful for Eastern State Hospital patients in filling these strategic gaps. Next, I will overview diagnoses and statistics to give context for what we're seeing clinically before we move into the application. OT integration is especially strategic for high-impact patient populations, such as those experiencing first episode psychosis, schizophrenia and schizoaffective disorder, severe depression with psychomotor slowing, dual diagnosis such as serious mental illness as well as substance use disorder, forensic restoration units, and long-term state hospital patients transitioning back into the community. While many of us may be familiar, I'm going to highlight a few diagnoses briefly for those who may not be as familiar. Schizophrenia is a chronic condition affecting thought and perception. Oppositional defiant disorder is persistent defiance, irritability, and often with outbursts. Eating disorders are unhealthy eating patterns that impact health and functioning. Bipolar disorders are often episodes of both mania and depression that alternate. Depressive disorders are characterized by ongoing low mood that affects daily functioning. Borderline personality disorder is characterized by intense emotions with impulsivity and instability. Obsessive compulsive disorder is characterized by obsessions caused by anxiety, which are relieved by compulsions. Anxiety disorder is excessive fear or persistent worry that interferes with daily life. Post-traumatic stress disorder is persistent stress after experiencing or witnessing trauma. It's important to recognize that mental illness is very common in the United States. This is not rare. It's something that we see across all settings. About 1 in 5 adults experience mental illness every year. For severe mental illness, that number is 1 in 20, and for youth, 1 in 7 experience a mental health disorder each year. To put this in perspective, think about how many people are in your circle, friends, family, colleagues, and then think about how many of these people in your circle are likely impacted by mental health based on these numbers. So we have 1 in 5, 1 in 20, and 1 in 7 impacted each year. Yet, only 57% of adults experiencing mental illness are receiving treatment. Luckily, that does jump to nearly 71% for adults living with severe mental illness, but it drops back down to only around 50% of youth receiving treatment. All of these people could benefit from treatment, so this is quite the gap. Quick question. How long is the average difference between onset of mental illness symptoms and receiving treatment for adults in the United States? The answer is 11 years. Can you imagine waiting 11 years for a broken bone? That is the average, meaning some people wait even longer. Why does this 11-year delay matter? Mental health impacts overall quality of life. Unemployment is around 3% higher. Substance use risk is doubled. Physical health risks like cardiovascular and metabolic issues are also doubled. And while 40% of suicide deaths had a diagnosis, 90% had symptoms. This is why 11 years is too long to wait from symptoms to treatment. Let's delve into the suicide risk a little bit more. Many people don't realize that people who use tobacco products have a 2 to 4 times greater risk of suicidal ideation, planning, attempt, or death. This is one reason why our Eastern State Hospital tobacco replacement and treatment programs are so important. Stopping tobacco use can reduce suicide risk by improving mental illness symptoms, such as decreasing anxiety, depression, and stress. Then there's the financial crisis, which is a major factor for suicide. The cost of cigarettes varies by state, but can be a significant portion of income for many individuals. For example, even in Kentucky, it costs about $200 per month to purchase 1 pack a day. Beyond tobacco cessation positively impacting suicide risk, the literature shows that tobacco cessation also aids recovery. People living with mental illness are 2 to 3 times more likely to use tobacco compared to those not living with a mental illness. However, tobacco cessation can reduce symptoms related to anxiety, depression, and stress, can help improve their financial situation as well. For example, people living with schizophrenia spend over 1/4 of their income on cigarettes each month. Research also shows that tobacco use hinders recovery through worsening physical health outcomes, mental health symptoms, less expendable income available, and also housing difficulties. So, thinking back on the key diagnoses that we discussed, how tobacco impacts suicide risk and overall mental health recovery, and how common mental illness is among us, 1 in 5, 1 in 7 in youth. There is no health without mental health, and yet the average wait from symptoms to treatment is 11 years. Given all of this, what is the role of occupational therapy in mental and behavioral health settings? Occupational therapy began in 1917 in response to a rise in mental health concerns among injured World War I soldiers. We have come a very long way since then. We have evolved into a science-driven, holistic profession that promotes health, participation, and independence across the lifespan. In many ways, we have maintained our roots in mental health as well. To further educate on the full scope of occupational therapy, here are some of our areas of expertise, from technology and rehabilitation to workplace interventions to upper extremity evaluation and intervention, neurological, sensory motor. There are many different areas that occupational therapy works in. I'll talk about a few of these more in depth as I go. What are some specific areas that occupational therapists can address? OT practitioners often target physical, cognitive, emotional, and environmental factors to support independence, health, and overall quality of life. You can see from the breadth of areas on this slide that we do a lot, from creating custom orthotics to neurorehabilitation, and our work blends biomechanics, neuroscience, mental health, environmental design, and much more. Doctors of occupational therapy also have additional training in research translation, system level leadership and practice, new program development and implementation, policy and advocacy, new care models, and preparation for roles in academia. Occupational therapists also evaluate how psychiatric symptoms affect activities of daily living, such as morning self-care, instrumental ADLs, which can include medication management, budgeting, meal preparation, and other similar tasks, executive functioning in task context, sensory processing and regulation, habit formation, role restoration, and much more. OT provides skilled, performance-based interventions grounded in occupational science. By addressing these areas, occupational therapy can reduce readmissions, decrease behavioral incidents, improve placement retention, and improve independence in valued occupations. Recovery-oriented models emphasize participation and role restoration as central to mental and behavioral health recovery. Occupational therapy operationalizes recovery through measurable task performance. OT integration is most effective when it's embedded early in admission, not as a late consult before discharge. While working on the occupations discussed in the last slide, you must consider a person's individuality, which is often influenced by their patterns, such as roles, routines, habits, and rituals. These 4 performance patterns are foundational in occupational therapy. This is important because one of the main causes of readmission is loss of identity while being an inpatient due to removal from typical performance patterns, except for possibly some rituals. Here we're focusing on role-related impacts. When mental and behavioral health symptoms go untreated, individuals may struggle to meet expectations in roles that are very meaningful to them, such as parenting, work, or caregiving. A key factor is executive functioning, especially working memory, which is often impacted in mental health conditions. For example, for parents, this can look like difficulty with everyday tasks such as meal preparation, remembering school drop-off and pickup routines, helping with homework, and other important role-related activities. Routines are the predictable patterns that help organize the day. When symptoms persist without treatment, individuals may struggle to maintain consistent daily routines which support functioning. Routines are especially important for mental health because they create structure, stability, and predictability. Without this structure and predictability, someone may feel unprepared for work or have difficulty completing basic routines such as showering due to a lack of support or consistency in their daily life. Habits are everyday occupations that support functioning and well-being. These are the automatic, repeated behaviors that structure our daily lives. Sleep is one of the most commonly affected habits, with many individuals experiencing changes in sleep quality and duration when experiencing a mental health challenge. For example, someone with schizophrenia may have difficulty falling or staying asleep due to hallucinations, delusions, or paranoia, which can make it hard to feel safe or settled enough to maintain healthy sleep patterns. Rituals are meaningful, symbolic activities or events that often carry personal, cultural, or social significance. Rituals often require social engagement, which can be challenging for individuals experiencing difficulties in social functioning. For example, when invited to events like weddings or funerals, a person may feel significant anxiety or discomfort, and they may ultimately choose not to attend due to their symptoms. These 4 areas highlight how mental and behavioral health conditions can impact everyday functioning, and they also demonstrate the importance of occupational therapy in supporting participation in each of these 4 performance patterns. I want to briefly mention just a few of the more common screenings and assessments that you might see an occupational therapist using to assess mental and behavioral health across settings. Just as an interview does not equal performance, screening does not equal functional observation. Many occupational therapy assessments are activity-based. Research shows that real task performance better predicts functioning than symptom scales alone. Even when cognitive screens look intact, performance-based assessments can reveal issues with sequencing, planning, task completion, or other executive function related challenges. For example, a client may understand medication management but struggle when actually organizing a pill box. This is why observation of functional tasks is key for discharge and community readiness decisions. The COPM, Canadian Occupational Performance Measure, is an assessment that measures self-perception and performance in any daily occupation that the client finds meaningful. This measure tracks changes in functioning over time and is an awesome standardized assessment that occupational therapists use. The Coleman Evaluation of Living Skills, also called the CELS, is a tool that assesses a broad array of living skills that are needed for safe and effective community living, from self-care to money management. The Allen Cognitive Level Screen, also called the ACLS, is a cognitive level screening that assesses functional cognition by observing how an individual learns, problem solves, and follows instructions during a structured activity. The General Health Questionnaire 12, the GHQ-12, assesses social dysfunction and psychological distress. The questions delve into someone's sleep, leisure activities, performance in daily occupations, and much more. As many of you are likely familiar, the Columbia Suicide Severity Rating Scale, the CSSRS, is one of several tools available to assess suicide risk across a large population. So now let's review the types of occupational therapy interventions, including a few you might see when an OT is treating here at Eastern State Hospital. These are core areas of occupational therapy intervention in mental health. Evidence supports OT interventions in mental health for improving occupational performance and participation. There are countless OT interventions that can be used within these core categories listed, depending on the client's needs and goals. Executive function is something that impacts every one of these areas. It is strongly correlated with poor community outcomes in serious mental illness. Occupational therapists assess initiation, sequencing, time management, and problem solving, which are just a few areas of executive functioning within live tasks, not simply through a questionnaire or interview. Sensory regulation is involved in these interventions as well. Sensory modulation difficulties are increasingly recognized in psychiatric populations. Evidence supports sensory-based interventions to reduce seclusion, restraint, and agitation in inpatient units. Occupational therapy provides structured sensory assessment and intervention planning. Sensory processing differences significantly impact psychiatric behavior. Research supports sensory-informed environments for reducing agitation and restraint use. Patients may become agitated in high-noise environments or withdraw in overstimulating spaces. Occupational therapy can help with this by providing sensory and environmental assessment, but also during intervention, applying modulation strategies, environmental adaptation, and helping with de-escalation planning. In group therapy sessions, occupational therapists design and lead structured group sessions that target specific skills. For example, one group may promote coping and mental health self-efficacy, while another group may focus on cognitive skills and executive functioning. We are able to grade tasks, provide immediate feedback, and improve cognitive functioning in ways that translate to real-life functioning through group therapy sessions. Occupational therapy interventions use meaningful, structured activities to help people build social and emotional skills such as self-regulation, communication, and relationship building. This is especially important in inpatient psychiatric settings and behavioral health settings because emotion regulation can reduce the symptoms of mental and behavioral health diagnoses and result in overall improvements of mental health, behavioral health, and well-being. OT interventions incorporate task modification strategies such as lifestyle redesign and task grading to adjust the complexity, habits, and environments of activities so that individuals can participate more successfully and independently in their valued occupations. Lifestyle redesign is habit-based, focusing on prevention, health promotion, and health management by helping individuals develop healthy habits in their daily life. Task grading focuses on grading tasks based on their current level of performance to promote the just right challenge. This allows for individuals to not feel overwhelmed but work towards a goal. This could be providing visual supports so that an individual can more effectively, independently manage their medication or remember meal times. For individuals with mental health and behavioral health concerns, the development of coping skills has been shown to promote resilience, self-regulation, and wellness. By promoting these skills, occupational performance and participation in valued activities can improve. Mindfulness is one example of a coping skill. This can have a positive impact on depression, anxiety, stress, and sleep quality. Discharge is a very high-risk transition point. They may have concerns like, what if I don't have a phone, a car, a place to live? Occupational therapy helps with preparatory actions such as supporting transitions and re-entry into daily roles. This helps individuals with daily functioning, routine, and community participation upon discharge. Occupational therapy interventions may help them prepare by navigating public spaces, learning about local transportation systems to attend follow-up appointments, helping establish follow-up care, and helping them prepare to meet their other basic needs. This can help reduce the risk of relapse and readmission due to providing a more structured discharge plan and transition period. Occupational therapy addresses stress management through practical strategies like relaxation, routine building, and environmental supports. Research shows that structured interventions improve functioning in conditions like bipolar disorder. Interventions are individualized and often focus on one's routine, their sensory regulation skills, and coping skills to support daily participation in activities. Occupational therapy interventions for stress management teach practical coping strategies such as relaxation, activity scheduling, and environmental modifications. These can help individuals regulate emotions and maintain balanced daily routines. Shown on this slide is a study of people living with bipolar disorder, where structured interventions targeted daily functioning, routines, and coping strategies, which luckily led to significantly improved psychosocial functioning. Every plan is unique, but interventions for a case like this may focus on routine stabilization, sensory regulation, relaxation techniques, and structured therapeutic activities to help regulate stress and encourage participation in daily life during recovery. Leisure is more than our free time. Research shows that participation in leisure activities can support resilience and overall mental health. Research shows that engaging in a wide variety of leisure activities is linked to even better outcomes. Occupational therapy can use structured leisure interventions, such as leisure exploration, to improve well-being, performance, and life satisfaction in psychiatric populations. If an individual is used to using substances or tobacco during their free time, it can be a difficult transition when they are trying to cease these activities. Thus, it can be helpful to explore new leisure activities to fill their time and promote recovery. Now that we've talked about occupational therapy skills and interventions, we're going to talk about occupational therapy as part of a multidisciplinary team. Now let's consider the perspectives of occupational therapists and psychiatric mental health professional roles. There are some things in common because most healthcare professions work with the same patients, care about function and quality of life, and use overlapping language like goals, skills, and recovery. But each discipline looks at the patient through a different lens. An occupational therapist may ask, how are symptoms affecting your ability to live your life? A psych mental health professional may ask, what are the symptoms? Occupational therapy may ask, how is depression disrupting your routines and roles? A psych mental health professional may ask, how severe is the depression? Occupational therapy may ask, can you initiate, sustain, and complete daily tasks that are important to you? A psych mental health professional may ask, is the medication working? Lastly, an occupational therapist may ask, are you able to structure your day in a way that supports recovery? A psych mental health professional may ask, are you safe? Now let's break down the perspectives of each team member a little bit deeper. Occupational therapy ensures that patients can perform the tasks required for daily life independently and sustainably. Occupational therapy translates stabilization into lived function. These are tiny snapshots to define how the focus of each profession is slightly different. Occupational therapy may ask, can this person do what they need and want to do in their daily life? And if not, what's getting in the way? Psychology may ask, how do thoughts, emotions, and behaviors interact? Nursing may ask, is the patient medically and psychiatrically stable right now? Peer support specialists may ask, how can my lived experience with mental and behavioral health support someone else's recovery? Social work may ask, what social or systemic barriers are affecting recovery? Recreational therapy may ask, how can meaningful recreation improve quality of life? Physical therapy may say, how does the body move and recover physically? And lastly, art therapy may ask, how can creative expression support emotional healing? Occupational therapy does not duplicate psychotherapy or medication management. Instead, OT translates clinical stabilization into sustainable daily living. Working with a patient through symptom stabilization and functional recovery lenses side by side might look something like this. For example, if medication is successfully stabilizing the symptom of hallucinations, then a focus on medication self-management in occupational therapy is likely to lead to functional recovery. Similarly, if mood stabilization is being achieved, occupational therapy can help work on ADL independence. If a client has reduced agitation, symptom stabilization, occupational therapy can begin helping them build structured daily routines to maintain this. Strategic OT integration contributes to reduced readmission rates, improved step-down replacement retention, decreased behavioral incidents, and increased patient satisfaction. Occupational therapy documentation also strengthens justification of skilled services and continued stay when appropriate. Clinical integration often includes early referral triggers to occupational therapy participation in daily rounds, standardized ADL screening for all clients, and leadership integration, which can include tracking functional independence metrics, aligning OT with readmission reviews, and embedded performance criteria into discharge planning. Some questions to consider. Are we equating stabilization with readiness for discharge? Are we consulting occupational therapy early enough? What functional gaps are driving readmissions? While there are many more, I wanted to include a few resources and advocacy groups in this presentation to help you take this learning even further. We are all familiar with the National Alliance on Mental Illness, NAMI, including the important role that they serve here at the hospital. AOTA, or the American Occupational Therapy Association, is OT's national professional association. There is also the Kentucky Occupational Therapy Association, KOTA, just as many other professions also have. And you'll see select resources beside each organization that I found helpful. This training will be available online in a couple of weeks, so you'll have access to my slides at that time in case a resource stands out to you. Here are a few of the top psychiatric-focused organizations, including the American Psychiatric Nurses Association, or APNA, the Substance Abuse and Mental Health Service, SAMHSA, as well as a few more resources. Along with national organizations, BeWell, which stands for Behavioral Health Wellness Environments for Living and Learning, is the research team that support the Eastern State Hospital Research Council. We host a number of free CE opportunities, and we also have a large number of evidence-based resources. So if you have not yet taken a look at our website, it is full of free and excellent resources, so I recommend taking a look. There are a number of organizations that are not only health profession specific, but population specific. The Trevor Project is one of those and is specifically designed to link to LGBTQ+ educational resources and crisis services. Before we reflect, let's look at two case studies and how occupational therapy may impact the care and treatment in these instances. The first case study looks at medication adherence, schizophrenia, and readmission. Executive dysfunction is common in schizophrenia and also bipolar disorder and severe depression, by the way. And executive dysfunction may look like initiation difficulties, poor sequencing, disorganization, reduced problem-solving capabilities, and OT evaluates these skills within real-world tasks, which are tied directly to post-discharge sustainability. Perhaps a patient stabilizes when they're in the hospital, but readmits within 30 days of discharge. A common cause of this is collapse of routine. So, what can an occupational therapist do? In this case, occupational therapy addresses medication rehearsal, visual cueing systems to promote medication adherence, habit formation also to promote medication adherence, environmental structuring, scheduling practice, and many other interventions. Habit integration is a very critical predictor of sustained medication adherence, which is where OT could contribute. In this case study, we're considering acute hospitalization for a client with major depressive disorder, severe, passive suicidal ideation with anxiety and panic. The client says, "My brain won't shut off. I'm a burden." Think about when you would refer occupational therapy. Occupational therapy supports self-regulation and daily functioning during periods of mood instability, helping clients manage symptoms through structured routines and coping strategies. Occupational therapy focuses on remaining functional barriers like psychomotor slowing and difficulty initiating tasks. Interventions use graded activity engagement to rebuild participation in meaningful routines. The goal is improved real-world functioning and sustained daily engagement, not just symptom improvement. So, a quick time to reflect. If OT was not included on our unit tomorrow, what gaps in patient care might appear? What OT key words do you see here? Coping routines, functional, sensory processing, environmental triggers, and more. When you see a need for these types of interventions, you now know it is a great way to know it's time for occupational therapy to be involved if they are not already. Here are the questions we may ask ourselves. Beyond medication adherence, how are we helping patients develop coping routines that reduce crisis cycling? Are we assessing sensory processing patterns and environmental triggers for patients who are agitated, shut down, or overstimulated? Beyond symptom reduction, how are we addressing functional discharge readiness? Are we observing how a patient plans, organizes, sequences, and problem solves during functional activities? Are we tracking improvements in symptom scales along with improvements in occupational engagement? How is hospitalization affecting a person's sense of role as a parent, student, or partner? And are we helping them rebuild that identity? What are some measurable outcomes that leadership can track? Leadership can track occupational therapy impact through measurable outcomes like ADL independence, medication management, routine participation, executive functioning, behavioral incidents, readmission rates, and discharge success. These metrics show how patients function in real life, not just symptom change. Stabilization prevents immediate crisis, but functional restoration prevents system cycling. Strategic OT integration strengthens patient outcomes, regulatory alignment, and long-term cost containment across Kentucky's behavioral health systems. Here, we will now complete the knowledge post-check. Please know that if you are requesting CE credit, the completion of the post-check is required. Please scan the QR code or use the link and complete the post-check now. I would appreciate knowing if today's topic is meaningful to you. This is necessary for those desiring continuing education credit and appreciated from each of you. Your feedback can help make this learning module better for future learners. I greatly appreciate and value your feedback. Here are the references. Thank you for participating in this CE and let's work together to integrate occupational therapy practice in mental and behavioral health. If you would like to contact me with any questions or comments, my information is listed below. Okay. Thank you for attending, everybody. I appreciate you listening and learning more about the role of occupational therapy in mental and behavioral health. So the floor is now open for any questions that you may have. That's what I was thinking.
I have a question. And you'll have to repeat it when you keep on screen. We mentioned that OT had it started in mental and behavioral health. Did it ever veer off of that, or has it always had that as a base?
So the question is, OT started in mental and behavioral health, but did it ever veer away from that? And the answer is yes. We actually kind of joined the medical model not long after World War I. I'd have to remember exactly when, but we did kind of join into medical. And then I think occupational therapists were like, we're more holistic and kind of outside the box than that. And so they advocated to kind of return to our roots. And it's been that way for many decades now. So, but we did have a lapse in that where we veered away from mental behavioral health quite a bit more physical oriented.
But I have a comment and a question. So the comment is, I'm quite impressed with the overview. It really clarifies occupational therapists' role in action.
Thank you.
So that's the first time I've actually understood occupational therapists. And I think it's principally because they take a holistic approach. And I kept seeing they use really a lot of the biopsychosocial model, integrated model to healthcare. My question is, in terms of inpatient versus outpatient roles for occupational therapists, one of the big things is to help with functionality. How do occupational therapists help people move from learning things that can help them with functionality to actually doing things that can help them with functionality?
That's a great question. So the question was, occupational therapists can help people in inpatient and in outpatient learn about how to function in these different settings, but how do you not just help them learn, but help them apply those skills in real life? So I would say the answer is that's why our interventions are activity-based. And so very rarely would we teach something without applying it. I don't think that would ever happen. I think the goal is always to teach it and then we're going to practice. And even if you're in an inpatient setting, you could teach about the bus routes, for example. You could have a printout of those, but say, where is somewhere that when you leave here, you will need to go? For example, their follow-up appointment. And we will literally go through the bus route map and the times and have them plan out their route. And then if possible, go into the community and help with that. But that's the importance of transitioning them to an outpatient OT as well for when we can't transition. But for meal preparation, as another example, they can practice meal preparation up here if they're concerned about not being able to eat or, feed themselves. They don't feel capable of a task that requires so many different skills and so many different steps. Our goal is always to engage in the actual activity. So.
Thank you.
Yeah, of course. So. All right. Well, thank you everyone for being here. And this training will live on the Be Well website for 3 years. So feel free to reach out to me through my email. My name is Claudia Rose, as a reminder, with any questions or
comments. So thank you.